figured out that their therapists were wrong and kept looking for answers. Sexual obsessions and OCD are common. As a result, it is difficult to know exactly how many people with OCD suffer from sexual obsessions. One of the largest studies of clinical OCD symptoms was the DSM-4 field trial, which included patients receiving treatment from top OCD specialty clinics at 7 urban sites. 17% of patients reported current or past sexual obsessions as a primary or secondary concern. In a large nationwide study, 30% of those with OCD reported sexual and/or religious obsessions, but it is not known exactly how many of these experienced sexual obsessions since the two categories were combined. In another study, a quarter of treatment-seeking individuals were found to experience sexual obsessions at some point in their lives, and the authors of that study believe this was an underestimate. Between 20% and 50% of those with OCD report sexual obsessions in international samples. These sexual symptoms seem to complicate the treatment process, as such patients spend, on average, 3.4 years longer, over 30% longer, in treatment than people with other types of OCD. But because sexual obsessions and OCD are frequently misdiagnosed, many may never make it into treatment at all. Thus, the number of those with sexual obsessions and OCD is probably much higher than what was found in the 20-year-old DSM-4 field trial, or even the more recent study by Grant and colleagues. Shame and embarrassment prevent many sufferers from telling anyone about their frightening sexual worries, even patients who may be in treatment for other forms of OCD. Most people with OCD have worries in more than one area, and failure to address all symptom areas can facilitate treatment failure or relapse. Why another OCD manual? The current selection of available instructional materials does not provide much help for clinicians who want to better understand clients with sexual obsessions. Although we have written scholarly articles about this type of OCD, these are not accessible to the majority of mental health service providers, most of whom do not have access to academic databases. The selection of popular treatment manuals is not of much help either. Our own investigation into this matter found that none of the best-known OCD treatment manuals describe how to treat sexual obsessions, and only one had even a single page dedicated to this area. Likewise, we found that most self-help books for OCD omit the topic altogether. Those of us with decades of experience treating OCD can easily use general CBT principles to develop an effective treatment plan for just about any symptom presentation, including SOCD. But for the majority of clinicians who don't do this every day, it can be tough to turn abstract principles into action. With existing manuals, one is left trying to figure out how to take a sample exposure hierarchy written for a person who is deathly afraid of getting asbestos-related cancer, and to infer how to make it work for a patient afraid of molesting his 4-year-old daughter. Even examples of how to treat violent or religious forms of OCD, which are likewise scarce, are likely to be of little help to the average therapist treating a client with sexual orientation fears. Therapists may struggle with not knowing what to do or how to do it. We are frequently contacted by clinicians encountering their first client with sexual obsessions. Inevitably, both the client and therapist are frightened and confused, and the sexual aspect of the problem makes therapists even more uncertain. Our practicum students routinely face skepticism and ridicule from their fellow student therapists when they describe treatment of their SOCD cases in university supervision classes. Treating SOCD requires courage and conviction by the therapist in the face of pervasive miseducation and lack of awareness. Common questions asked by students, therapists, and others include, how do I know if this is OCD? What if a client really does have a paraphilia? Should clients be encouraged to explore alternative sexual experiences? Where is the line between reassurance and psychoeducation? How far is too far when it comes to sexually evocative exposures? How can one distinguish between anxiety and sexual arousal? What if the patient becomes sexually aroused during an exposure? How do you address mental compulsions? How explicit should imaginal exposures be?